I will give my point of view of what still surgery can do for intermediate risk patients and consider TAVRs from a critical point of view. I have nothing to declare as a disclosure. And modern aortic valve surgery started with Harken in 1960, being the first to successfully replace an aortic valve with a mechanical cage ball valve prosthesis. But only 2 patients were long-term survivors of that first group of 7. More than 50 years after those initial valve replacements, the implantation technique has not substantially changed. However, big improvements have been made in patients' preoperative assessment, operative procedures and materials, as well as postoperative care. At present, we have available information of very long-term outcomes in numerous and comparable patients. As a result, for aortic valve replacement, conventional surgery is today the gold standard against which all other options should be compared. Currently, different types of valves are available, appropriate for all ages and anatomic characteristics. They are mechanical valves, low-profile biological valves with or without stents, and bioprosthesis can be implanted without sutures also. Progress in this area promotes the feasibility of tissue valves in younger patients and in other subgroups at high risk for valve failure. A large number of patients who have an indication for aortic valve replacement do not undergo surgery. As an example, data of the survey conducted in 2001 by this society showed, among other findings, that 33% of patients older than 75 years with symptomatic severe aortic stenosis did not undergo surgery. For various reasons, high risk, advanced age, few symptoms, or because of the patient's or family decision. Subsequently, the option of a transcatheter heart valve entered the scene, and steps that followed aimed at finding the role together with conventional surgery to broaden the spectrum of treated patients. In this scenario, surgical database risk scores, together with frailty scores and the judgment of heart teams, are extremely valuable. 4 categories of patients were established according to their risk: extreme, inoperable, high, intermediate, and low. Using this classification, different trials are defining the indication for surgery or TAVR in a very selected group of patients and in a markedly changing scenario. In light of those results, TAVR is today accepted as the best options for very high risk or deemed inoperable patients with symptomatic severe aortic stenosis. Among others, mainly PARTNER 2 and SURTAVI trials assessed intermediate risk patients. Some ongoing and future trials will speculate on low risk and younger patients. Both PARTNER 2 and SURTAVI trials reached similar conclusions at 2 years. In symptomatic patients with intermediate risk, TAVR was not inferior to surgery regarding all-cause mortality and disabling stroke. TAVR and SAVR had different patterns of adverse events associated to each procedure. SAVR had more acute kidney injury, bleeding, and atrial fib. TAVR had more major vascular complications and paravalvular leaks. We need to emphasize that these randomized prospective trials were conducted in highly selected populations. Patients were symptomatic and their mean age was around 80 years. Real world is somehow different. Many patients differ from those included in the trials. Such intermediate risk group of patients are younger, some asymptomatic, others have concomitant procedures to treat or special anatomic situations. In this European multi-center retrospective observational and propensity match study, after comparing conventional surgery, TAVR, and sutureless valve among more than 600 patients, the conclusion was, our study does not support the deliberate use of TAVR in patients with aortic stenosis and an intermediate risk profile. All this information is reflected in the latest update of the American Heart and College guidelines for the management of patients with valve disease. Surgery for intermediate-risk patients with severe symptomatic aortic stenosis is class 1, it means recommended, and TAVR is class 2, it means reasonable. In the real world, according to the STS database, of all isolated IVRs who underwent surgery between 2006 and 2010, before the widespread of use of TAVR in the USA, only 14% were patients with intermediate risk score. Should be emphasized that approximately 40% of those patients would be excluded from the big trials. Those are not ideal candidates for TAVR, like patients with high risk for paravalvular leaks, when a ROS or a mechanical valve is preferred, those anatomic situations like an enlarged aortic root requiring replacement, patients needing major concomitant procedures, when aortic insufficiency is the dominant lesion, patients with low-lying coronaries and narrow sinuses, or when an endocarditis is present. While the opposite, those are good candidates for surgery. It's interesting to see that in the German aortic valve registry between 2011 and 2013, when TAVR in Germany already was a frequent indication, the incidence of surgery in older, intermediate-risk patients was also around 14%. In a scene where TAVI seems a tsunami, what surgery has to offer to intermediate-risk patients? First, a continuous improvement in hospital results. There is a tendency towards risk reduction throughout time as a consequence of preoperative risk factors evaluation and intra- and postoperative management. This analysis of almost 110,000 patients from the STS database operating during a 10-year period until 2006 shows that risk-adjusted mean hospital mortality decreased around 35%. Mortality assessed by age group also decreased significantly, especially in patients older than 80 years. And findings were similar when the incidence of stroke was assessed in age group patients. Among almost 20,000 patients operated in the US between 2002 and 2010 with an intermediate risk score between 4 and 8, mean complication rates for the whole period were relatively low. Stroke, 2.3, heart blocks, 5%, new dialysis, 3.3%, operative mortality, 5.8%. Divided these patients into two groups, the first operated between 2002 and 2006, and the second, more recently, between 2007 and 2010, predicted risk of mortality was similar. Hence, patients had similar operative risk factors, but the observed risk of mortality was significantly reduced from 6.4 to 5.4. There are surgical options also to reduce trauma. In this regard, minimally invasive aortic valve replacement, defined as an AVR performed through a small thoracic incision instead of the traditional complete sternotomy, is an option. This consists of a small lateral thoracotomy or a partial sternotomy in the upper end of the sternum. The lesser surgical trauma in these patients results in less blood loss, decreased need for respiratory support, and greater patient comfort due to lower pain levels with early mobilization and a better cosmetic result. As a complement to minimally invasive approach, in recent years and inspired in the transcatheter health valves design, aortic prosthesis with the characteristic of surgical biological valves and some of the advantages offered by TAVR were introduced. Two main options are available in the market, the Edwards Intuity and the Sorin Perceval. Both are made of bovine pericardium, and their main characteristic is that they don't require sutures to fix them to the aortic annulus. They are implanted under direct vision, under extracorporeal circulation through an opening in the aorta. After resecting the native valve, and decalcifying the annulus, the prosthesis is deployed, as I said, under direct vision. Multiple registries and some trials, like this one from Germany, shows that the greatest advantage for sutureless over conventional valves lies in the 30 to 50% reduction in aortic close clamp time and extracorporeal circulation time, as well as their better hemodynamic performance to reduce mismatch incidence. This European multi-center experience with sutural valves shows that among more than 700 patients with a mean age of 78 years with intermediate risk and up to 5 years of follow-up, hospital mortality, incidence of stroke, moderate or severe leak, and need for a new pacemaker implantation were all similar to those of patients undergoing conventional surgery. In summary, these prostheses make minimally invasive surgery simpler. Incidents of important complications are similar to conventional surgery, and they have an excellent hemodynamic performance. Because of the shorter ischemic time, benefits are more evident in patients with intermediate to high risk and those who need combined procedures. But, as with transcatheter hair valves, long-term durability results are still pending. Another important point related to surgical AVR, and especially in patients with intermediate risk due to their frailty and those who have a longer life expectancy, is the lower incidence of long-term, life-threatening major complications. Some are related to the procedure itself, like residual paravalvular leaks. The results of the PARTNER 2, the TAVR trials, and the SAPIEN 3 registry that address patients at intermediate risk showed an incidence of residual moderate or severe and also mild leaks extremely less in SAVR than in TAVR. These numbers are important because, as it is concluded in PARTNER 2, at 2 years, mortality in patients with moderate to severe leaks was 2.5 times higher than in patients with absent of trivial leaks. Of note, patients with a mild residual leaks in high-risk patients of the PARTNER B trial also had a significantly higher mortality than patients with no or trivial leaks. Given the high incidence of mild leaks present in close to 30% of patients after TAVR procedures, long-term follow-up is warranted, especially when younger patients will be addressed. Also, new heart blocks needing a pacemaker implant are lower with surgery, especially in a comparison with self-expanding TAVRs, as it is seen in the TAVR trial. In the TVT registry, the need for a new pacemaker after TAVR is associated with higher mortality and a composite of mortality and heart failure admission at 1 year. Other complications are value related. 2 years ago, in the New England, McCart called our attention about a probable thrombosis in the leaflets of TAVR valves. This finding led to the decision to conduct 2 single-center registries, the RESOLVE and SAVORY, recruiting more than 900 patients with TAVR implants of various brands and also with different surgical bioprostheses. From those studies, here are shown 4D CT images in different types of TAVR and, in the right column, a surgical bioprosthesis. All exhibit a shadow in the stenosis that reduces the valve opening, as in the systolic images shown in the lower row. The appearance is suggestive of thrombosis, since in many cases regression was documented after anticoagulation therapy. They were not related to the occurrence of stroke, but to a significant higher incidence of TIAs. Leaflet thrombosis was significantly lower among surgical bioprostheses, 3.6 in surgicals versus 13.4 in TAVRs. This may possibly indicate an early stage of structural valve deterioration, but for now, this is only a sign of alert, a suggestion that they should be assessed further to confirm its real incidence and the potential need to add anticoagulation therapy. We know what are the long-term durability of most surgical valves. Structural deterioration is the most important limiting factor for bioprosthetic valve implants at the early ages. This figure shows follow-up with echo results among 28,000 patients stratified in three age groups, below 60, 60 to 70, and above 70 years, who underwent surgical implants of bovine pericardium valves. In patients older than 60 years at the time of valve implants, structural damage begins to increase at approximately 10 years. Among patients older than 70, freedom from structural valve deterioration at 15 years by echo was around 91%. Information about structural deterioration of TAVR valves is scarce and anecdotal. Accordingly to data presented last year at the PCR, around 50% of patients had echo signs of valve deterioration at 7 years post-implantations. It is difficult to assess the applicability of this information in a context of fast technological development and moving targets trying to include younger patients. But one thing is certain. Before a transcatheter heart valve could be indicated in younger patients, longer-term follow-up information is needed. Cost is not a minor issue. There is a marked difference in the cost of TAVR procedure, especially due to the cost of the prosthesis itself, which is about 25,000 euros more expensive than the valves used in surgery. Patients at intermediate risk, in whom mortality is similar for both groups, for the cost of TAVR to approach that of surgery, there should be either a marked mortality advantage or an very important reduction in its hospitalization time. In conclusion, TAVR is a class 1 indication for intermediate risk patients. Although it's reasonable to indicate a TAVR in some intermediate risk patients, many of them, especially younger and not good candidates for TAVR, are benefited from surgery. Only 14% of aortic valve replacement patients are at intermediate risk, and surgery is customized to their characteristics: age, anatomy, risk scores, frailty, heart in point of view, and patient's wishes. Options to decrease surgical trauma are relevant in intermediate risk patients, especially when a concomitant procedure needs to be addressed. Our daily challenge is to make the right indication today with the information we have right now and not with what we presume will be in the future. Thank you.
Dr. Cnojek, excellent presentations. Carlos, your team have developed and validated a new score for raised stratification. I know the limitation of STS and Euroscore 2. Any comments about Argent score with your experience to select the patients?
Well, the first thing is that scores are only one piece of the information we should take in account for the decision. From that being stated, our score is developed in our country with our own patients, with our own way of operating, and it is, for us, it is much more accurate than the STS and the Euro scores. It is very important for us to, since it is an additive score, it is very important to consider which one of the risk factors we can reduce. For example, to make better the renal insufficiency, to make better the functional respiratory status. It means for us it works very well, and it is very useful from that point of view.
Okay, thank you. Great presentation, Carlos. I am Dr. Vera Janabel from Argentina also, Sanatorio Las Lomas. Well, I would like to know after your presentation, it's very thoughtful insights into surgery versus TAVI. I would like to know your opinion about patients with bicuspid aortic valve disease. We know that now we are considering that this an aortic disease more than a valvular disease. And maybe this is a good point to discuss about surgery versus TAVI. What's your experience?
Yes, I think that surgery will last for many years. For sure, in some long time from now, new people will ask how surgery was, because they wanted to know. But nowadays, I think still surgery has many patients to treat. And it should be a combined procedure with the option of a TAVR, and with the discussion, as we already seen in the previous presentations. And those patients that has abnormalities, that have some pathologies in the subvalvular region and in the aorta, we have to do some combined procedures, replacing the aorta, replacing the valve, or making a myectomy. Those are patients that we still will have to operate. I don't think they have an option with a TAVR today.
Okay.
Thank you.
Okay, thank you very much.